go ahead and jump right into the lecture. I tell you, when you're trying to give a test during the lecture time that is already limited, it is just no good, let me tell you. Seems to be self-defeating, you know. All right, so we are going to continue our discussion about care of patients with urinary problems. And of course, as you all know, this is Adult Health 2, 1650. Let's see. And these are some of your objectives, which I want you to be able to do at the end of our discussion. This particular picture here, what is actually showing is a stone, as you can see it on this diagram. Just to give you an idea of what it would look like on an X-ray. They actually call this a KUB. And KUB is kidneys, ureters, and bladder. So it's a form of an X-ray that is able to provide you an image of a stone within the urinary tract. And of course, these are some priority concepts for this chapter, or a priority concept for this chapter. Elimination, which is very obvious. That's what the urinary system does. It eliminates urine, which is a form of waste product. The interrelated concepts for this chapter: comfort, immunity, as well as tissue integrity. All right, so the first topic we are going to look at is cystitis. And this is essentially an inflammatory condition of the bladder. All right, and it usually refers to inflammation from infection of the bladder. Anytime you see the ending itis on a term, as you all should know by now, there's an inflammation. But don't think that just because you see itis, that it always means infection. It is not always synonymous with infection. It could be just an inflammatory disorder of some unknown etiology, or of some things that we might think might be contributing to the inflammation. For example, irritants can cause cystitis without infection, without an infectious organism, such as there's certain drugs, chemicals, local radiation treatment can also inflame the bladder, especially that latter one. You know, when patients are receiving radiation treatment for cancer, the radiation itself can cause an irritation or an inflammation of the bladder tissue. There's also in what we call interstitial cystitis, which we'll discuss, but interstitial cystitis, which is an a painful inflammatory bladder condition. Again, not necessarily all the time, an infection with these patients. Now, an infection can occur in any area of the urinary tract as well as the kidneys, and this is what we refer to as a UTI. All right. And when we think about other irritants, such as you can see in this slide, it talks about irritants that can cause cystitis. There are other irritants that might be implicated in causing UTIs, such as feminine hygiene sprays. So that means that you as nurses must teach your patients, especially your female patients, about feminine hygiene sprays and that the fact that they can cause, they can become very an irritant to the bladder. There can also be spermicidal jellies and also long-term Foley catheter use can occur without infection as well. All right. Now, cystitis can also occur as a complication from other conditions such as PID or AKA pelvic inflammatory disease. It can also be due to Crohn's disease as well as lupus. And of course, as you know, Crohn's disease and lupus is an autoimmune, the autoimmune type of disorders. So in this regard, sometimes our immune system attacks certain tissues. So just think about it in that regard. I'm going to ask you to read page 1355. There's a table that I want you to look at. It's table 66-3. And this just talks about factors that contribute to UTI development. Things like an obstruction can lead to a UTI, because if you think about it, let's say, for example, you have some stones. Let's say if you have a stone in the urethra, all right? Urethra is a part of the urinary tract. Or if you have some kind of obstruction, maybe a stricture or something like that, remember that means that the urine cannot continue to flow on out of the body. And so that urine stays stagnant within your bladder and also within the urinary system. And of course, that can lead to infection. Stone formations can cause UTIs if a patient has diabetes. Gender, remember females, they have a much shorter urethra. If you think about your anatomy, both male and female, it's a little more difficult for a male to get a UTI than it is for a female, because with females, the urethra is short. Compared to a male's urethra, it is much longer. So because the male's urethra is longer, it takes some distance for the infectious organism to travel from, let's say, the tip of the penis into the bladder. It takes some time, but for females, it's such a short distance. They're just more susceptible to UTIs. Also, age, sexual activity, and recent use of antibiotics can also cause UTIs as well. So just take a look at that table. It talks about the mechanism or how it occurs. For example, for obstruction, It says incomplete bladder emptying creates a continuous pool of urine in which bacteria can grow. It prevents flushing out of bacteria and allows bacteria to ascend more easily to higher structures. So, in other words, if the urine is stagnant and because of an obstruction, it cannot, the urine cannot be excreted from the urinary system, then the organism can actually travel upward and towards ultimately your kidneys. And this is why some patients, they get what we call pyelonephritis, which I have a voiceover on pyelonephritis for you all to look at, just an FYI. Now, infections can be acute, meaning they happen within a short duration, but they can also be recurrent, and we'll talk about that. An acute is an invasion of the normal GU tract by an infectious organism. All right, that would be your acute. As far as your recurrent, what that would look like is a recurrent infection occurs, or there's actually greater than 2 infections in 6 months. All right, so you'll have greater than 2 infections in 6 months, or these patients may have 3 infections in 1 year. And so this would be considered recurrent. All right. And so knowledge of the different types, you may wonder why we need to know about different types of UTIs, but the knowledge of different types is very important because there would be a difference in how you treat these conditions. So you must understand the various types. Now we can further subcategorize UTIs into complicated versus uncomplicated. All right. So when we're talking about uncomplicated, these are patients who do not have any anatomical or functional abnormalities of the GU tract. In other words, the structure, the anatomy of the GU tract is all normal. All right. There's nothing that may be causing any obstructions or anything that would prevent the outflow of urine. Again, everything is normal. All right. And so patients without risk factors that can lead to an infection is likely to be treated and recover or have a much better outcome when they do not have any risk factors. Risk factors such as like if someone has maybe diabetes or something like that, maybe some other autoimmune disease even. When you think about we have to immunosuppress these patients to kind of calm down their immune system. Other than that, if you're without a patient without risk factors, with the proper treatment, they can heal much easily. But they do have to follow the treatment regimen correctly. And that means things like drinking enough fluids and taking the antibiotic like you're supposed to. Oftentimes what happens with patients is they tend to, let's say if the doctor places them on antibiotics for 10 days, they tend to take it, the first few days or so, they begin to feel better, and then they decide to stop. Well, that's not following the treatment regimen normally like you're supposed to. Now, the other type of UTI is referred to a complicated UTI. And this occurs in pregnancy. It occurs in the male gender. And the reason what we mentioned here, the male gender, and this would be considered a complicated type, is because, as I mentioned to you, with males, it's much more difficult, especially younger males. It's difficult for them to acquire UTIs as opposed to their counterpart females, because again, the urethra is much longer, and so it would take it takes more for the organism to travel from, again, the tip of the urethra all the way to your bladder system, and then even further than that. So it just takes a whole lot more. So, but when you do find a UTI in a male, then it will be likely complicated, is what they're saying. Complicated UTIs can also be found in patients with diabetes, with patients with CKD. And so these are just some conditions or some factors that I just mentioned that can contribute to complicated UTIs in these patients. There's some additional information there for your reading as well. I was talking to you all the other day about your reading. One of the reasons why, again, I have to reiterate why doing your reading is important is because when you look at my speaker notes, you'll see where I talk about, for example, I mentioned complicated UTIs being in pregnancy, male gender, diabetes, CKD, and then I said, et cetera. The et cetera is referring to the fact that I didn't list everything. And because I didn't list everything, because otherwise my speaking notes would be huge. What this means is you need to go to your book and look at that additional information. So this is why doing your reading is vital if you're going to get the information. All right. Now, typically in complicated UTI, well, in men, as I mentioned, UTIs is usually complicated, but you would typically find a UTI, or it's not difficult to find UTIs in older men. Because even when you think about older men, I mean, their immune system, as you get older, of course, is not as strong as it was when they were younger. And of course, they have some other factors. Their immune system is just not as strong. And also, those who engage in anal intercourse, they can also develop a UTI as well. Because remember, in the anal area is where E. coli reside. And E. coli is an organism that you will likely find in females who have a UTI, especially if they wipe the wrong way. You have some females who may not be aware that you're not supposed to wipe from back to front. And so if you wipe from back to front, then you're dragging that organism into the vaginal area, which is, of course, where the urethra is located. And so these women can acquire a UTI. So even with the anal intercourse with males, again, you're talking about that the organism E. coli that can bring about an infection. Now, when a male it does have a UTI, which we know is typically complicated, they will require a longer course of antibiotics to treat this condition. Now, again, in men, when they do have a complicated UTI, it's usually associated with other comorbidities. Again, things like maybe diabetes can increase their risk of developing complicated UTIs. So they have some other things going on that would cause this to happen. All right. There's a term that we called bacteriuria, and this is just based when whatever you see the urea is it's referring to urine, of course, but this is essentially bacteria in the urine, and it does occur with cystitis as well as UTIs. And of course, we do have a way of checking the urine to see if the patient does have bacteria growing. All right. Now, sometimes our patients will have this bacteriuria without signs and symptoms. And when they have this condition without signs and symptoms, we refer to it as colonization or asymptomatic bacterial UTI. And you will find this commonly in older adults. And this condition can progress to an acute infection, and it can also lead to renal insufficiency if the patient has any other health problems or health concerns. And of course, this will require prompt treatment because you don't want that acute renal insufficiency to lead to anything that is chronic, and the patient will have renal failure for the rest of their lives or CKD for the rest of their lives. So this will require prompt treatment. Now, when you think about the urine is actually sterile until it gets to the tip of the urethra. Other than that, when you think about the urine in the urinary system from the urethra, except the tip, all the way to the bladder, to the ureters, and then to your kidneys, all that urine is sterile. This is one of the reasons why we talk about these clean catch urine specimens, where you have a patient. So if male or female, if you're given a specimen, you clean starting from the urethra and then outward with some kind of antiseptic pad, and then you urinate, and then midstream you catch it. All right. And that's because if you didn't do it that way, then that bacteria, hold just a minute, somebody just came in. I guess Ms. Carter got kicked out.
No, I'm teaching over back to my laptop.
Oh, I see. All right. Let me go back. All right. So yeah. So when these patients do a clean catch, you have to instruct them that they have to wipe properly and catch the urine midstream. Otherwise, that bacteria that is normally located on the urethra, on the tip of the urethra, will give you a false reading. And so you don't want that. All right. Now, there are several what we call several host defenses. We're the host, and we have some defenses that can help us to that can protect us against infections, thereby decreasing any chances of a urinary tract infection. So the urine pH, remember, the more acidic urine is, some organisms, or most organisms, cannot survive in a low pH. There can also be what we call mucin, or a kind of mucus, urine proteins. There's also prostate gland secretions of protective proteins, and also when you urinate. This is the reason why after sex, you would often tell people to urinate, because the urine will cleanse the urinary tract. So, in other words, any organisms that are ascending, traveling towards the kidney, starting from the urethra. When you urinate, you can actually flush the organism away. So these are just several defenses that we have to protect us or to protect the urinary tract. All right, and so it is certainly important for you all to know what organism that is likely to cause UTI. And as you can see here, it is E. coli. Again, if a woman is not wiping correctly, or if a male is having anal intercourse, it doesn't matter with who, it can lead to a UTI infection. So this occurs in about 90%, or 90% of UTIs occur due to this infectious organism. Candida is another infecting microbe that can occur when patients are taking antibiotics for a very long time. You know, you think about patients, let's say a patient has osteomyelitis. Those patients are actually on antibiotics for at least about 6 weeks. And of course, because of that, they can acquire Candida, or Candida is also a fungal infection. All right. And catheters are the most common factor associated with new onset UTI in the care setting, whether that be an acute care setting or a long-term care setting. All right. Now, when we talk about UTIs, we talk about a high bacterial virulence. When we talk about virulence, that's virulence, virulence. And this is the ability to infect, you know, basically the strength of the organism. Its ability to invade and to infect. Or it actually requires a pretty high virulence, or a pretty strong bacteria in order to overcome our normal defenses and our normal immunity. Our normal defenses or immunity is usually able to fight back these organisms. And so that's why it really requires an organism that is very powerful. All right. And so this is why when we think about our patients who have a compromised immune system, they're more susceptible to even low bacteria virulence. So even if the bacteria is not that powerful, if a patient's immune system is compromised, they can also develop an infection. I already talked to you guys about what is considered an ascending infection that starts from the external urethra and then it travels to the bladder, and this can cause cystitis with infection, of course. All right. All right. Also, when we think about bacteria has a special adhesion or its ability to stick to the mucosa walls that lines the urinary tract. And this enables it to ascend or travel from, again, the lower urinary tract all the way up to your bladder, or even your kidneys for that matter. All right. So they just have the ability to adhere to the mucosa, the mucous membrane of your urinary system. Infectious cystitis can come from the bowel, as I mentioned to you. Remember the E. coli, and also from the vagina. If a woman has an infection, a vaginal infection, remember the urethra can be found is located rather somewhere in the vagina. And so if a woman has an infection, then the organism can get into the urethra and begin to travel upward or ascend towards the bladder. Now, other microorganisms that can, or microbes that can cause an infectious cystitis would be your viruses, your mycobacteria, as well as parasites, etc. All right. Irritation, trauma, or even instrumentation when a patient has a procedure, in other words, can also impair the host defenses and can cause a migratory pathogen. Migratory meaning it can migrate, it can move towards the bladder as well, which can lead to infection. So think about if someone has a procedure like a cystoscopy procedure, and if the equipment is not clean, then this can also cause your patients to develop an infection. All right. Now, this is very important for you to know. Catheters are, again, the most common factor associated with new onset UTIs in the care setting. Again, that's acute or long-term, it doesn't matter. Within 48 hours of a catheter's insertion, bacterial colonization will begin along the urethra and along the catheter itself. So it will begin to grow at that point. Let's see, for just a minute, I want to check something real quick. All right. Yeah. So anyway, and so when these catheters are inserted in your patients, it doesn't cause an infection immediately. It will likely start off with more of a bacterial colonization, meaning it begins to grow, but you don't have quite an infection as of yet. It takes about 1 week for patients to become infected after insertion of a catheter. And this is the reason why, especially in your acute care settings, you will find that if a patient goes to a procedure or has surgery, they try to discontinue these Foleys as soon as possible, because sometimes you may have to insert a Foley. For example, if you're working around a certain body structure and you want to put a Foley catheter into the bladder in order to decompress the bladder, because you don't want to nick the bladder and whatnot. And so, or other reasons why this patient should have a Foley. Once they're back from that procedure, at some point in time, at least maybe within the next day or two, you want to remove it. They call these CAUTI, catheter-associated urinary tract infections in the hospital. And one of the big issues with these is the third-party payers, your insurance companies, or even Medicare. If a patient develops a CAUTI in the care setting, they won't reimburse you for it because we have to do all that we can on the healthcare clinician or healthcare providers side to minimize these things from happening, because it can prolong the patient's hospital stay, can cause more complications for the patient. And therefore, we want to make sure we're doing all that we can do. And this is also why catheter care is so important as well, making sure you're cleaning these catheters in order to minimize. Sometimes you will think to yourself, it just makes no sense why they are removing these catheters from these patients, especially those who cannot get up and use the bathroom and they're incontinent. You know, urine can be excoriating. You know, these patients, they're incontinent and that urine gets on their skin They may be even incontinent of stool as well. And it destroys the skin. You have this severe breakdown. And you would think it would just make more sense to just leave the Foley in so that, you don't compromise the patient's skin, causing a more severe complication. But then they rely on us as healthcare staff to keep the patient clean, which is very difficult at times, especially when you've got a whole lot of things going on and you have very little ancillary personnel. In other words, a tech or a nursing assistant and what have you. Very difficult. Very difficult. All right. Let's see. We talked about that. Now, when men develop a UTI, a catheter can be a pretty big cause for that. Also, when you think about the Foley catheter and the tubing that leads to the bag itself, that is your closed urinary drainage system. And if there's a break in that system, all right. For example, if you have to detach the catheter from the tubing itself because you want to flush it, if you don't use proper sterile technique or aseptic technique when you're doing this procedure, not only are you breaking the system, which is fine if you have to flush it, but if you don't use the right technique to do that, then organisms can move through the catheter's lumen and can ascend just like any other infection, causing a problem with your bladder, your kidneys, and so forth. So make sure when you are breaking the seal on that closed urinary system, you do it the proper way. All right, so the external or the outside of the catheter, organisms can also migrate from that point and through the GI or the GU system, which is why it is so important. Which is why it's so important for we as healthcare providers, we must do meticulous cleaning or care of these catheters in order to avoid that. On page 1356, I want you to look at chart 66-7, page 1356, for ways to minimize catheter-associated urinary tract infections, or AKA CAUTI. For example, maintain unobstructed urine flow. And what that means is you would keep the catheter and collecting tube free from kinking. Sometimes when these patients, when they're on bed rest, depending on if they may be lying on the tube or maybe the way the tube is placed on the bedside, on the side of the bed or whatnot. If you're not careful, sometimes these tubes, they can kink. And if they kink, then you don't have adequate urine flow, meaning the urine pools, it stays stagnant. And when it's stagnant like that, it's kind of like standing water. Things can grow in standing water. Same with the urine. If it's stagnant and not moving, then it can cause an infection. Also, keep the urine collection bag below the level of the bladder, and do not rest the bag on the floor. Sometimes you'll go in the room and you'll see the Foley catheter bags sitting on the floor. You know what's on those floors, right? So you want to make sure that hook that is located on the catheter bag, you're going to hook that on the side of the bed. So that's very important. You also want to keep that bag, that drainage system lower than the bladder, because if you raise it, then that urine is going back into the bladder. Also, it talks about empty the bag regularly using a separate clean container for each patient. Now, I'll tell you right now, we don't usually do that. Now, I have a pet peeve about that. Typically, because resources are not readily available, in every institution. So we typically take the drainage container, and once we empty the Foley, at least I do, I actually clean it. I run a lot of water in it in order to clean it. What I see some healthcare providers do, they empty the urine through that in the container, and then they'll pour it in the commode, and then they'll just set it right on the in the bathroom or wherever, without cleaning it. And you can tell it's not clean because it looks really bad. So just go ahead and make sure you take a look at this. Maintain good hand hygiene during insertion and manipulation of the catheter system to avoid contamination. So there's a slew of other things I want you to look at here. You should know this while you are managing a patient's catheter. So take a look at that. Let's see. So we talked about patients who are on long-term antibiotics, how they can develop these fungal or candida type infections. Remember, antibiotics tends to change the normal protective flora, which reduce adherence and volume of pathogenic bacteria. So remember, we as humans, we already have a certain amount of bacteria that is kept in check by our immune system. And of course, when these patients take these antibiotics, that environment is altered, and therefore these patients become susceptible to developing these fungal candida type infections. All right. Sometimes it just can't be helped. Depending on the patient's illness and how long they have to take it. As I mentioned to you, osteomyelitis, that requires antibiotics for a long time. And even these patients who might have these methicillin resistant types of infections, it just may require a much longer time. So sometimes it just cannot be helped. Now, patients who are severely immunocompromised from either, again, such as your diabetes, your other autoimmune disorders, or even patients who take medications like steroids, they are also high risk for developing the fungal type of UTIs. All right, immunocompromised. Remember, there's a difference between immunocompromised and immunocompetent. When you're immunocompetent, you have a pretty strong immune system. But when you're compromised, then your immune system, you can acquire certain diseases because your immune system cannot fight. Now, you also have these non-infectious cystitis that can result from chemical exposure. And what do we mean by chemical exposure? For example, there's certain drugs like Cytoxan. We also talked about radiation, immunity issues such as your lupus or any of the other autoimmune disorders can lead to the non-infectious type of cystitis. Now, we also talk about interstitial cystitis, and interstitial meaning the tissues of the bladder. So these patients, now this is rare, where they might have an interstitial cystitis for some reason or another. The tissues of the bladder becomes inflamed. It is rare, but it is also considered a chronic inflammation that typically affects the lower GU tract, such as the bladder, the urethra, and any adjacent pelvic muscles. So it's more the lower GU tract that is impacted by interstitial cystitis. Now, this can be related to genetic immunity dysfunction. So, in other words, the genes, heredity may be implicated here. But again, no infection is involved here, but these patients, they just have this inflammatory thing going on with their bladder. Women are more affected than men, and this can be pretty difficult to diagnose as well. As far as signs and symptoms, when you think about signs and symptoms for interstitial cystitis, there's pain associated with bladder, when the bladder fills up with urine, or when a patient voids, urinates, they can have pain. Other symptoms will be frequency, urgency, nocturia, getting up at night to urinate quite a bit. Pain also occurs in the suprapubic or pelvic area as well. And these patients also have pain radiating to the groin area, to the vulva in females, and also in the rectum as well. And again, this affects women more than men. Cystitis, it can be life-threatening. Let me put a hyphen here. It can be life-threatening, and it can lead to pyelonephritis as well as sepsis. And as we know, sepsis can lead to death if it's not treated properly. Predisposing factors to UTIs are these patients who have diabetes. Actually, I went over this, the diabetes, pregnancy, anatomical abnormalities as well. So I talked about that already. Now, UTIs is a source of infection, typically for severe sepsis, or that can result also in septic shock in about 10 to 30% of our cases. So I would tell you that most of the time, if a patient come in and they're septic, getting a urine culture is probably going to be one of the main sources that a culture, a specimen will be obtained, since that comprise a pretty good percentage of severe sepsis or septicemia. Now, when an infection does occur in the urinary tract, it can travel and cross over into the bloodstream. And when it does cross over into the bloodstream, we refer to that as bacteremia. The mia end of it is blood, or urosepsis. And when you think about sepsis is a pretty severe condition that our patients can acquire. And it's basically a systemic reaction that can lead to shock. It can shut down many of your organs, and it has so many other complications as well. But usually in severe sepsis, just about all of your organs are impacted, and people go into multi-organ failure as a result. Now, sometimes these patients, and this is very important, sometimes your older patients who come into the acute care setting, maybe from a long-term care facility because something went wrong, they will likely come in with they may come in with urosepsis as well. And one of the most common signs and symptoms for these patients who are coming from these facilities is that they may have developed some mental status change, all right, because they are infected. And so because of this, the healthcare provider will want to, again, obtain that specimen so that you can identify the offending organism and provide the right treatment or antibiotic. I'm not sure if I told you all about this, but when you get a culture from a patient, whether it be from the blood or any other area of the body, the urine, the sputum, or what have you, you will see this report, this lab report, that will show you different antibiotics, and it would also show you next to those antibiotics the letters S as in Sam or R as in Romeo. The S stands for sensitivity, and the R stands for resistant. So if you look at a patient's, look at that patient's data, and you don't want to place this patient on something that says, that has R next to the antibiotic, because it means that it's resistant and it's not going to treat the patient. It won't fix the patient. And so you want so your physician will look at all the medications or the antibiotics that are sensitive, or that the organism is sensitive to, right? Because these tend to be more successful in getting rid of the.
Professor,
Yes.
I have a question.
Yes.
Give a patient like resistant, I guess, antibiotics, is that how you can build up to become septic?
Oh, say that again. I'm sorry, say that again.
I said, if you were to give a patient's like their, what you said, the receptive or restricted, what would you say the R stood for?
Oh, the R is resistant.
Okay, so if you were to give them like resistant medication, is that antibiotics, is that how they become septic? If you keep giving them the wrong kind, or is that something completely different?
Well, it's not because they become maybe they may develop a sepsis because you're giving them an antibiotic that's not working, which means that the organism is going to invade your system even that much more. That can lead to sepsis. In other words, with a resistant antibiotic, you're not fixing the problem. The problem, it remains, and it may get worse. Does that make sense?
Yes, sir.
Yeah. So, yeah, then that's why I don't know if you all ever seen that before, but if you work in hospitals, maybe you can get one of the nurses or someone to show you that report. But it just shows you. Let's see. You know what? Let me see something. Sensitivity and resist. Resistive report. I don't know if I can bring up sensitivity resistance report. I don't know if there's like a chart or something that I can show you. Would be nice. I can show you a chart. But yeah, so I don't know if I'll be able to find this, but so basically you just see the R's and the S's, and you always want to give the S's because that's what the antibiotic is sensitive to. Otherwise, you're not doing anything, and you're going to basically cause the patient to have greater problems. So it's always good to treat it with the right antibiotic or antimicrobial therapy. So it looks like I can't find it. So anyway, so hopefully you guys will be able to see that when you go back to the hospital as well. Let's see, where am I? All right. So remember those older patients that come in from these long-term care facilities, and when they develop mental status change, always be thinking about, there may be some urosepsis going on, because remember, older men in particular are more susceptible to urinary related infections. They have already compromised immune responses and whatnot. They just don't respond very well to their immune system is just not as strong as it used to be. So they're just more susceptible to infections and whatnot. All right, folks, go ahead and take 10 minutes and meet back at 11:10.
My connection was going in and out. What did he say? What are we doing?
Take a break until 11:10.
Okay, thank you.
So it looks like I was having some connection issues as well. So let's give the other ones some time to come on.
I've been having connection issues since yesterday.
Really?
Yeah, and my internet just shut out and I had to reset the box again. So it just got back up.
Yeah, I think a lot of this is because more people are at home now working.
And the kids are starting school now. My kids tomorrow, so and a lot of others have already started.
And it's been storming too. So
Oh, it's the storm. Where are you located?
I'm in Gainesville.
Oh, you're in Gainesville.
Yeah, mine stormed. Yeah, it stormed here yesterday, and my internet kept knocking us out yesterday.
But darn, we don't need this. Come on now. We don't need this. All right, let's see. Got 15. I need 17 total. Is Miss Cameron on? This is Miss Witherspoon.
Dr. Weaver, my internet is being weird as well, so you might see me jumping on and off trying to fix it.
Yeah, I understand. Trust me. Mine was messing up as well. I got 16. Start recording. How was this lecture sounding to you all so far? Does it sound too complicated?
No, something that I can relate to.
Yeah, especially being a female and these UTIs. Yeah, definitely. The thing about being a nurse in healthcare, you tend to, you're getting all this information, so you tend to kind of, you tend to use it for yourself or on yourself. And so we can actually stay a whole lot healthier because we know what to avoid and things that we must do to promote our health. So hopefully you can use some of these, some of this knowledge to help alleviate any of these problems if these are things that you suffer from. I know someone who suffered from UTIs since they were about maybe 4 years old, and they get like maybe 2 or 3 or so a month. And nobody can figure out what the problem is. I'm thinking maybe she has some kind of structural issue that could be causing her to have them more frequently. Anyway, so let me go ahead and share. All right, where are you? All right, so now we're talking about incidence and prevalence of disease. When I was in nursing school, I used to ignore this part here. I wasn't too concerned about it, but as you grow into nursing, you begin to understand the importance of looking at your incidence and prevalence, what groups are impacted more. So if you can, just pay a little more attention to this part as well. For example, the incidence of a UTI is second only to upper respiratory infections in the primary care area. And that's a lot when you think about it. So this lets you know, especially if you become a nurse practitioner or something like that, then this is what you'll see a lot. This is what you'll be treating a lot. So you become quite the expert in managing UTIs. And it is the most common health care associated infection. All right. There's some terms I want you all to also understand. These terms are basically urine abnormality signs and symptoms. For example, you hear about the concepts frequency, dysuria, and urgency. Frequency means an urge to urinate frequently in small amounts. Dysuria is basically painful or burning with urination, especially in pregnant women. And urgency, that feeling that you get when you want to urinate. You just feel that urge to urinate, but you just can't. I don't know why I put that there, but anyway. All right, so this is that health promotion and maintenance part that you guys really need to pay attention to, not only for yourselves, but for your patients, because you might have to teach your patients. So there are some national patient safety goals, and these are guidelines that have been developed in order to prevent UTIs. As far as fluid intake, there should be liberal fluid intake of 2.2 liters for women, and you want to remember these numbers, and 3 liters for men. And of course, always think about contraindications, because you might have some patients who, let's say if you have a patient who has heart failure or CKD or some other problem where they have fluid overload, so and they require fluid restrictions. So this may not be so easy for them. You also want to make sure your patients are urinating at least 1.5 liters of clear or light yellow urine daily. So you want their fluid intake to bring about this amount of urine output. And also there's some health teaching about amoxicillin for females, which will be on page 1360, chart 6610. So make sure you read that as well.
Professor Weaver.
Yes.
So what for the ones that have the amoxicillin allergy, isn't it like a Cetaphil or something? That's the second one. Is that important to know, or are they only going to focus on the Cillins?
Well, I wouldn't so much focus on that, because what we have a kind of a technique is with advanced care providers, where we look at this list of medications where you have your first line, second line, third line, and whatnot. So if you're allergic to one thing, then they'll just go to the next line that you're not allergic to. There's a drug app called Hippocrates. Not sure if you all ever heard of that. But it gives you a wealth of information about how to prescribe medications and whatnot. And I think the subscription is a kind of an expensive subscription, but it's really nice. I mean, it just tells you, like, for this particular condition, you'll give this antibiotic as a first line, or you give this one as a second, third, or fourth, and whatnot. So in this case, if you're allergic to it, then they just go to the next line, or something that that organism is also sensitive to, but not in that that particular line of antibiotics that you're allergic to, if that makes sense. Does that make a little sense?
Yes, sir. I just didn't know if they were gonna, if this like NCLEX or whatever questions to basically say if a patient is allergic to the Psyllium family, what would be the second type of medication. I wasn't sure if we needed to know that.
No, no, that would be kind of above you, above even me at this point. That mostly would involve your like your nurse practitioners, your physicians, and PAs or whatnot. And if you all can, I mean, just take I think you have like limited access if you do go into Epocrates. I think I'm going to see if maybe we can even get some kind of discount. Maybe you all can sign up for it. I think when I signed up for it, one of our instructors, because I guess she got the entire school or she had a lot of students that could actually sign up for it, I think instead of paying maybe $100, we were paying like maybe $40 or something like that. So, but it's a great system, let me tell you. I didn't even realize we were actually being tested with the material in Epocrates. I don't think the lady told us that we were being tested in it. Kind of crazy. Let's see, 66.
How do you spell?
Say again?
How do you spell that?
Let's see, let me tell you. EPOC-RA as an apple, TES as in Sam.
Thank you.
Yeah, it's a good system. Really, it's a great system. It has all kind of information. In fact, I think I may sign up for it again. There's an app for your phone, of course. There seems to be an app for everything. All right. So healthcare promotion and maintenance. This is a very important part of nursing because if we can do things to keep populations healthy, it would be so much better. And of course, save a lot of resources, much more cost effective. And you can decrease the complications that your patients may have if we can adopt this mindset in healthcare. About 95% of our healthcare is modeled, follows the medical model, meaning we wait till you get sick and then we treat you. And about 5% it follows the health promotion or that proactive form of healthcare. So we need to change that. And of course, by you being here in this program and this class in particular, you get to learn some health promotion techniques and things that you may want to go to some parishes or some women's health clinics or wherever, to teach young girls or what have you about how to maintain a more healthier lifestyle, if you will. And so that's why this information is so important. This is what you'll be teaching your patients. Now, this infectious cystitis, for the most part, it is preventable. Drinking a lot of fluids, as you read here on this slide. If you also look at page, I may have already told you all about told you all about this. Yeah. So I just have it written again. See page 1356, chart 66-7 for ways to minimize CAUTI. So just make sure you look at that. Also, remember what you learned in fundamentals of nursing a couple of terms ago, when you learn how to insert a Foley catheter under a sterile technique. That is very important. Because this can decrease infectious cystitis. Also, sometimes you have patients who may have to do in and out catheters at home. In other words, you have a dwelling catheter where they remain in place because you have that balloon on the end. Once you blow it up, it remains in place for a certain period of time. Those are your dwelling catheters, but you also have the the in and out catheters. They don't have a balloon because for some reason these patients are not able to void. And so they, when their bladder becomes too full, and so that the bladder doesn't rupture, then they will cath themselves to drain the bladder, and then they'll take it out. So typically at home, they're using a more of a clean technique, but there are less resistant forms of organisms in the home as opposed to the hospital. In the hospital, you definitely have to use sterile technique, but in the home setting, it's more of a clean technique that they use. Take a look also at page 1357, chart 66-8, for ways to educate your patients in methods of decreasing UTIs. For example, drink fluids liberally, as much as 2 to 3 liters daily, if not contraindicated by health conditions. Remember, I told you that if you have CKD, heart failure, or any condition where you have to restrict your fluids, then you don't want to tell your patients to drink this much water. Be sure to get enough sleep, rest, and nutrition daily to maintain immunological health. This is another thing to teach your patients. If spermicides are used, consider changing to another method of contraception. For women, clean your perineum, the area between your legs from front to back. I don't know if I said that differently last time, but you clean from front to back. Also for women, avoid using or wearing irritating substances such as douches, scented lubricants for intercourse, bubble bath, tight-fitting underwear, scented toilet tissue. Anyway, wear loose-fitting cotton underwear. So there's quite a bit here that talks about preparing for self-management, preventing UTIs that I want you all to read. Some stuff may kind of be more common sense to you. These patients should also be taught to avoid smoking because smoking does increase the risk of cancer in the GU system. There's also health teaching about amoxicillin for females when they have a UTI that you can see on page 1360. And so in this chart, it talks about amoxicillin. For example, it suggests that women who take oral contraceptives use an additional method of birth control while taking this drug, because these drugs may reduce the effectiveness of estrogen-containing contraceptives. So if you take this amoxicillin along with these estrogen-containing contraceptives, you might get pregnant. Now that's the short of it. But it's a short piece of information here, so take a look at that. So patients with recurrent cystitis should be encouraged to drink adequate fluids every day, and also to take hormone replacement therapy. Because usually when women are going into menopause and they have lower estrogen, they're more susceptible to UTIs as well. So that's why they're encouraged to take the hormone replacement therapy. Nurses should also question patients about immunosuppressant medications that they're taking, because these medications do tend to weaken the immune system and make them susceptible to cystitis. Remember, when these patients have these autoimmune disorders, let's say lupus or maybe multiple sclerosis, and they're taking these immunosuppressant altering medications. What you're trying to do is weaken the immune system to the extent that your immune system will fight against itself less. So that's the idea behind immunosuppression. When you think about patients who have transplants, your body's immune system will recognize that organ as foreign, as a foreign invader, and it will attack it. So the idea is for us, which it sounds counterintuitive, but you're giving these immunosuppressants to suppress the immune system so that when it responds to that foreign invader, it would do it with less intensity. And therefore, these patients can have these organs for a much longer period of time. All patients they do are reject, but it just takes longer because you are manipulating the immune system. Also, take a look at chart 6610. I just need to make sure I'm giving you all the right chart. Yeah, 6610, the same one. And look at drugs such as Bactrim, Cipro, and I already told you about the amoxicillin. So for example, with the Cipro, it talks about warn patients not to take the drug within 2 hours of taking an antacid to prevent interference with drug absorption. So if you do take this medication within 2 hours of taking an antacid, you won't absorb the Cipro very well. And if you don't absorb the antibiotic well, then your therapeutic levels are going to be reduced, and it won't be able to fight your infection. All right. So, and that's a very important thing to know as far as when you're studying your pharmacology, because you may be asked questions about when will you give someone, how would you instruct your patient who is taking Cipro and they're also taking an antacid. So this is something that's very important. And you would instruct them, do not take it within 2 hours of taking an antacid. So maybe you'll take it at 5 o'clock when you're going to take your antacid around 8 o'clock p.m. So, and I also talked about Bactrim. For example, with the Bactrim, ask patients about drug allergies, especially to sulfur drugs, before beginning drug therapy, because allergies to sulfur, this is talking about the Bactrim, allergies to sulfur drugs are common and require changing drug therapy. Some patients have allergies to sulfur. They have sulfur allergies, and your Bactrim does contain that. So again, very important reason why you want to, why your history is so important. Also, as far as Bactrim, teach patients to drink a full glass of water with each dose and to have an overall fluid intake of 3 liters daily, because these drugs can form crystals that precipitate in the kidney tubules. And so fluid intake can prevent this complication. So when these patients are drinking a lot of fluids, you're flushing out your system a lot. And so the less likelihood that will occur. So this is the reason why I wanted you to read that particular chart. All right. Let's see, where are we? I'm deliberately going a little slower on this because I'm just trying to cover a whole lot more. I'm trying to do more commentary as I talk about this, give you guys more examples. And I did quite a few voiceovers on some of the others, so we don't have to worry about getting to those. so quickly. If we don't get to them, we already have something for you to listen to and look at. So I'm just trying to be more deliberate. And when you're actually doing the reading yourselves, you'll be able to hopefully I'm modeling the kind of thinking that you should be doing when you're looking at this stuff. Assessing, noticing. All right. So as far as assessment is very important because you have to be able to assess these patients when they come to your institution and determine what is actually happening. And so this is why it is so important for you to know what assessment findings might be pointing to cystitis. So we talked about frequency, dysuria, and urgency, which I provided some information on that in the previous slides. We want to also assess the catheter for any problems. And also, this is very important. When a patient is going to have a physical examination, go ahead and get them to give you a specimen at that time, a urine specimen, because this will also allow them to empty their bladder. And this is because when the patient is lying on their back and you begin to palpate the belly, you don't want to press on the belly when their bladder is full of urine because it's very uncomfortable. All right, so have them to give you a specimen and thereby empty their bladder, and then you can proceed with your examination. And also you can perform a more focused examination of the genital urinary system. And what that means is you're basically just looking at the genital urinary system, simply put. And they might be even, they usually provide you with a little box that talks about a more focused assessment. I don't seem to see it here, but at any rate, just make sure you're focused more. I'm sorry, wait a minute. Make sure you're just focused more on the genital urinary system. So this particular textbook doesn't actually provide it. Well, but in other words, so everything that you are learning about the genital urinary system, just make sure you, if you have to, especially in the primary care setting, you're not in there to look at every single problem a patient has, but sometimes you're doing a more focused assessment based on the patient's complaints. So that's all I'll say about that. Also, I want you to look at page 1358, chart 66-9, and these are just common symptoms of cystitis. Frequency, urgency, dysuria. There's also hesitancy or difficulty in initiating a urine stream. There's low back pain. There's nocturia, incontinence, hematuria, pyuria, pus in the urine, bacteriuria, and so forth and so on. So just take a look at that chart. We also talk about some rare symptoms. Even under the rare symptoms, it talks about fever, chills, and so forth. So you're probably talking about something that might be going systemic at that point. And then they also talk about symptoms that may occur in older adults. Make sure you look at that also. It says the only symptom may be something as vague as increasing mental confusion or frequent unexplained falls. I think I may have told some of you, if not all of you, that anytime you see a box, a table, a chart, what have you, if the author of a textbook takes the time to create a box or table, you better look at it. A sudden onset of incontinence or a worsening of incontinence may be the only symptom of an elderly urinary tract infection. Fever, tachycardia, tachypnea, hypotension, even without any urinary symptoms, may be a sign of urosepsis. The patient is becoming septic, and because of the urinary infection. Loss of appetite, nocturia, and dysuria are common indications. So take a look at that box and especially focus on symptoms in the elderly. We tend to take care of more elderly patients than we do younger patients. So anyway, take a look at that box. Now, patients who have cystitis, they may have urine that is cloudy. Remember, urine should be clear. Foul smelling. Urine should, at the very least, have maybe that kind of ammonia kind of smell. Because of the urea in the urine, or it can be blood tinged, and this is when it's getting a little more severe. So be careful about that.
Professor,
Yes, ma'am.
I'm sorry.
No, go ahead.
But what causes the confusion or like disorientation in like older patients with UTI or something like that versus someone young? Because they don't find confusion in younger patients. Like what causes?
Well, they may be becoming, they're becoming septic a whole lot. You know, remember we talked about urosepsis. So this infection, it can impact their neurological system and other systems as well. So you'll see more confusion with these patients. Again, they're more easily, they will easily turn septic with a urinary tract infection as opposed to the younger population.
Yeah, I know tomorrow, like we had some patients that were frequent flyers, and we would know like they would begin to start being angry, like, okay, let's check them for a UTI, and that's what it was, or something like that, something so small, and then just end up on neuro because of it. So I was just curious, what was the difference between the two? But that makes sense, though.
Yeah. Yeah, you really have to watch. You have to watch. You always have to watch your either extremely young or your extremely older patients because they just react quite differently than your younger population who has a much stronger immune system. So, but that confusion is really big with these patients. Does that answer your question?
Yes, sir.
All right. Let's see. Risk factors for UTIs on page. You know what? I'll make sure. All right. All right. So risk factors for these UTIs. So take a look at page 1355. Again, do not neglect looking at this information. And so basically, we just talked about contributing factors that can result in UTIs, obstruction, renal stones, diabetes, gender, age, sexual activity. Recent use of antibiotics, sexual activity. So just take a look at that as well. Now, patients with Foley catheters can have signs and symptoms such as fevers, with or without chills. They will also have, when you get a urine specimen, they have these sediments in the urine. And of course, as we talked about, mental status change, etc. There's some additional information there. Foley catheters that have been placed, that have been in place for at least greater than 2 weeks, you can definitely suspect that the patient may have a UTI. So follow this procedure. If you suspect that the patient does have a UTI, and they've had this Foley in for quite some time, go ahead and change the Foley out first, and then obtain the urine CNS, culture and sensitivity. All right. You don't do the culture and sensitivity on that old system because it's likely going to have organisms in it already anyway. But if a patient truly has a UTI, you want to change that system out first because that system is more sterile. Go ahead and get your urine sample, and then it would be more accurate, if you will. You always want to look for signs and symptoms of infection, such as fever, increased heart rate, and also tachypnea. Sometimes these patients might have a distended bladder after they urinate. And so they basically just have an incomplete bladder emptying. And for those of you who are not familiar with the healthcare setting, we use what we call a bladder scan. Anybody feel comfortable using a bladder scan?
Yes, did it all the time.
Really?
Mhm.
Are you say you're a tech at one of the healthcare facilities?
Yes, I'm not anymore. I do home health now, but I was a tech for 2 years on neuro.
Yeah. I hate those bladder scans. I mean, they're good, but I always have a hard time placing them in the right region.
Yeah, the ones we have now kind of guide you, and they'll have, well, on our floor, they had pictures to tell you exactly where to go and how to make a perfect circle. So ours was pretty simple.
Yeah. Is it that kind of flat box?
Yes,
Uh,
sir.
Well, we have that too, and it has a little ultrasound, that black contraption that you put the what is it, the gel.
Mm-hmm.
Yeah,
It
we
was
have.
two types. We had a flat one, but the one probe actually had like a box, and it'll tell you exactly where to go and how
Uh-huh.
to make a perfect circle. So it did help. It helped a lot, but we stayed doing those all the time.
Yeah, I remember those. Well, I just wanted to see if I can show you guys a picture of a. I'm going to show you this one. I want to see if this is one that you're talking about. See. Yeah, so this is the one we have. Is this the one you're talking about?
That is one model, but ours is definitely more up to date. And the
Oh,
actual probe is a square. Like I said, it'll actually truly show you how it is. I have to find one and send it to you.
yeah, yeah. So is this thing right here is what I was talking about? Um, yeah, so we have to place this over the pelvic area where the bladder is located, and you go in different regions. It's like 4 different regions, right? From what I can remember. Um, so it tells you basically the amount of urine that is in the bladder. I think, what was the number? I think it was like if it's more than 250 cc's, then you have to either insert a Foley or in and out, do an in and out catheter. I'm trying to remember what we used to do when I worked in the hospital, but I think it's somewhere around 250 300.
Yeah, that's how ours was.
Yeah. So, but that's a bladder scan for those of you who don't know. And it has kind of like a ultrasound type of function or capabilities. A very weird system as far as I'm concerned. So, but anyway. All right, so just wanted to show you that. Let's see. So that's the bladder scan. You want to also assess the the urethra. Excuse me, meatus. All right, or the vaginal opening for signs and symptoms of a lesion or discharge or some kind of infection. I think somebody's getting kicked out. Oh, that's somebody in Brunswick. Who is that? That's Miss Creepin. She said the weather's getting bad here. I'm in Brunswick, Georgia. Miss Creepin, are you on?
Yes.
Oh, good, good. All right. I got you. If you all get kicked off, I am recording. At least I hope I'm recording. Was that the one you have?
Yes, sir. And so the probe is like it's a picture and it tell you exactly where to go. So that's what we have.
Oh, nice. That is nice. You see, but you see these four squares.
Hmm.
This is where well, I'm letting them know at least those who don't know where you're trying to place this that black device. And it'll show these square of these circles and the little grid here.
Yeah.
Yeah, that was always hard for me. I'm going to tell you, it was, you know, I eventually got it, but it was like just very difficult. Thanks for sharing that. That's all nice and fancy. What hospital was that?
North Florida in Gainesville. Shands has them as well.
Oh, well, Shands is a magnet hospital, so yeah, I guess they would have the latest and the greatest. I was so surprised when Shands became a magnet because it's one of those hospitals where, especially here in Jacksonville, where a lot of the indigent, they took care of a lot of the indigent population. And I worked there for like about 6 years, I believe.
I like it because they even have like the IV finders and stuff too. That makes it a lot easier.
Right. Oh, yeah. I forget what they call that, but yeah, we use those as well. Somebody invented that way back in the day when I was working at that hospital. I think that's when those came out. Um, but yeah, Shands is big time now. I tell you. Teaching hospital. Um, you guys will also be looking at some of my PowerPoint presentations on an enlarged prostate. And so just take a look at, I did a voiceover on it as well as I have PowerPoints on it. We probably won't get to it, but when you think about the prostate, see, the prostate sits right beneath the bladder and it surrounds the urethra in the male. And what happens is when that tissue grows, the tissue begins to push in on the urethra, causing an obstruction. And so, in other words, there is obstruction to urine flow. And this causes what we call urostasis. So in other words, the urine becomes more stagnated or pooled, and therefore these patients become high risk for UTIs. Causes colonization of the urinary tract, which may lead to an infection. I don't know if I'll be able to pull up that structure now, but you'll see what I'm saying. Let's see. State.
But did you call me?
Who was that?
Oh, I thought you were saying D.
Oh no, I didn't. All right, maybe this is a good picture. Just wanted to show you all a picture of what this actually looks like. All right, let me show you all this picture quickly. All right, so when we're talking about the prostate, this is the bladder here. See how this points to the bladder? That's the bladder. Can I make that bigger? Oh, I can. Well, yeah. Uh-oh. Didn't mean to do that. All right. So here's the bladder here, and here's the prostate here, right? And so in BPH, which is benign prostatatic hypertrophy, hypertrophy meaning this tissue, the cells of the tissue grows, it gets larger. And so ideally it would be nice if this tissue, when it grew out this way, in this direction. Unfortunately, and let me show you this too. This is the urethra, the male's urethra. Goes all the way to the tip of the penis here. This is the urethra. And so when that tissue grows inward, it will cut off this lumen. All right. And this is when the urine leaves the bladder, it gets stuck because there's this obstruction. All right. Another thing that, because I talk about this in my other presentation, when a man has a rectal exam to examine the prostate, this would be considered the posterior part or the back portion of the prostate. And this would be considered the anterior part of the prostate because this points in the front and this points to the rear or the back. So when your healthcare provider inserts a finger into the rectum, they're actually feeling the posterior aspect of the prostate. All right. From an anatomical standpoint, you cannot palpate the anterior portion because remember, as you can see, the rectum, it runs along the back portion of the posterior prostate, not the front portion. So when the finger is inserted, you're feeling for nodules. Nodules can indicate possible cancer. A prostate should feel like an eraser. I actually have a paper that is published, or not a paper, but a journal that is published on prostate health that I did when I was in my program, my doctoral program. So a pretty important subject for me, especially as I get older. These things become problems as with anything as we all get older. So that's what that looks like, and you'll see more of that when you look at the my presentation. All right. Let me go ahead and share this again. What time is it? 10 minutes. Be back at 12:10. Be back at 12:10. All right, looks like we're missing, you know what? Let's see, what time is it? 1:12. Stop this video and then restart it.